Cast is now starting. All attendees are in listen-only mode.
Good morning. Thanks for joining us today for our webinar. I'm Carmen Boone, Education Coordinator from Oregon Pacific Area Health Education Center, and today I will be your host and moderator. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted. They will remain muted during this session. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. Slides can be downloaded from the handouts option. Please use the questions options or chat option for typing your questions or comments at any time. This webinar is being recorded and it will be posted on our website. To obtain CME credit or CE credit for this activity, you must log into www.eeds.com and enter the activity code that you see on the screen. Please write down this activity code for your records. This webinar is produced by the Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital, and presented by Dr. Nadejda Razi Robertson. She is the Managing Director of Synergy Health Consulting, as well as Synergy's project lead for the Oregon Health Authority's Prescription Drug Overdose Prevention Project. Nadejda is a practice facilitator within health systems around the state of Oregon and provides technical assistance to clinics that are focusing QI efforts around safe opiate prescribing, MAT program development, and behavioral health integration. Dr. Andrew Suchocki is a family physician with additional training in preventive medicine. He has worked in underserved medicine with a focus on chronic pain and addiction for 10 years and has been a medical director at an FQHC in the Portland, Oregon region for the past 5. Andrew provides educational outreach and consultation in the areas of system change in primary care around opiate prescribing, MAT system design, and capacity growth, coordinated specialty care, and reducing risk. The presenters and planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. Now, without further ado, let's start with the webinar. And now you can see on your screens Dr. Suchocki and Dr. Nadejda Razi Robertson. They are going to start showing their screen right now.
Okay, let's see here.
Yes, we can see a white slide.
White, okay, so this is the same problem we had before, Carmen. So we're gonna do a main screen here.
Perfect.
This is why we test. This is why we do test runs.
Now it's working perfectly.
Great. Well, thanks so much, everyone, for joining us. We really appreciate it. Okay.
All right. Well, yes, welcome all. And we're going to do some brief introductions here. And then really would like to hear from all of you what you would like to get out of this session. So we'll have a moment for that down the road. Please feel free to just write any questions, comments in the chat box. Carmen will be watching and notifying us if there are things for us to be attending to. And should we go to our disclosures?
That sounds great.
So we'll just start by saying yes, no formal disclosures. One thing that I learned early on about Andrew is that he can draw just about anything on a bar napkin. And when we first asked Andrew to come on board with our health consulting team, it was after he had sketched out his risk stratification tool that he will be presenting to you later. But I just thought it was so impressive how much information he could capture on the bar napkin. And that was really the inception of our work together at Synergy Health Consulting.
Thanks. Although one time we couldn't find anything other than black napkins, and it was really difficult. With Nadejda, what impressed me about Nadejda is I've never seen someone who can actually just basically drink hot sauce.
Mm-hmm. Yes, I have a real hot sauce gift.
Yeah.
So those felt like important things.
So yeah, now that you know a little bit more about us, actually, there's probably a little bit more you may want to know as well.
Yeah.
Yep. So I would prefer to be able to take all my meetings by bike, and I continue to try to come up with new ways to take calls and be on webinars while on a bike. It's just really, really challenging sometimes.
And I love to sail and have a small little sailboat and enjoy sailing on the Willamette River and the Columbia, and have been, in fact, successful at joining some calls from the sailboat. So just a little bit, Carmen did give an introduction, but yes, so I am the Managing Director of Synergy Health Consulting, and for the past number of years, we've worked all over the state of Oregon, supporting efforts in improving safe opiate prescribing. And I would say as our work has evolved more and more now, the focus has also been on supporting efforts in developing medication-assisted treatment programs. We work both in primary care settings. That really used to be our primary focus, though again, as our work has evolved, we are more and more doing work across systems. So we've been working kind of helping communities really coordinate efforts across systems and across sectors. And supporting, in primary care and clinic settings, really helping all members of the team become kind of in more alignment. What we found is that oftentimes some of the biggest barriers to really being effective in making change when it comes to addressing addiction or improving safe opiate prescribing, addressing substance use disorder in primary care settings really can be when the team is not in alignment. And because these are topics that have often a lot of stigma associated with them, that oftentimes the stigma can end up really being one of the primary barriers to being effective in creating programs that are thriving. And so that really is a large focus of our work. And I think this talk really is going to primarily be featuring Andrew. Andrew has been working with Synergy. One of Dr. Suchocki's major roles is really providing technical assistance, case consultation, educational outreach to systems all over, not only the state of Oregon, but Dr. Suchocki also presents nationally, regularly. I think more and more really on MAT and getting MAT programs up and running. So Dr. Suchocki today will really be the primary speaker, really with his speaking on behalf of his role as medical director of Clackamas Community Health Centers, both really looking at how they have developed and evolved their programs around treating chronic pain and also treating substance use disorder in the primary care setting, and then now more specifically related to all that has changed so dramatically in this year of 2020 related to COVID. Andrew, maybe you could speak a little bit to that, and then we will open it up to all of you, and are very hopeful that you all will be willing to give us some context, where you're coming from and what you're hoping to get out of today's session, so as much as possible we can make this relevant for you all.
Well, Yeah, Nadejda, thanks so much for the introduction and the lead-in. I want to say that I don't know how many people here on the webinar have been to different COVID webinars, but I've probably been to maybe 5 to 10. And it's funny because typically there's like a topic it's about. It's like I did a COVID and diabetes talk, attending a COVID and diabetes seminar once, and it was 90% diabetes and 5 to 10% COVID. And I don't want this to be like that, but I do want to acknowledge that we're going to go into some fundamental things, some fundamental aspects of pain and addiction care and primary care that really get challenged when you have COVID involved, or a pandemic setting or distance care setting. And I think that's the thing that's the thing I really wanted to have you all have the expectation for when we talk more about this. I also just want to call out too that I think intuitively, most of us on this webinar can understand why treating chronic pain in a pandemic is more challenging, right? So there's practice setting issues, there's issues with policies and procedures that you've got set up. There's needing to make up stuff on the fly that could be stigmatizing or could cause problems accidentally. There are also intuitive things when it comes to the actual physiology and the pathophysiology of chronic pain and substance use that is worsened. If we think about isolation, we think about people not necessarily feeling safe to go outside, patients that may really but really thrive off of interactions and having social cohesion and a social network that is then shrunk down or different. And that resiliency that reduces their pain and maybe distracts them from substance use. Because really, let's be honest, when we look at the data, what really drives us for our abilities to cope with chronic pain a lot of times is frankly just things being active and having things to do and to get our minds more engaged so we don't perseverate. Obviously, the setting is challenging all that. It's turning it on its head. And so as clinicians, I'm about 1/4% clinical. So I have a patient panel of about 300 patients. The majority of them have some sort of chronic pain or substance use history in a community health center. And I've noticed that I've been challenged to some degree on that. So I've got patients either requesting more of a benzodiazepine or more of a chronic opiate, or that their Suboxone for their MAT or for some of their pain is not working well, and they're maybe on the max dose. And I've been noticing myself that it's kind of easy actually to say no when it's a phone call, because you don't have the person in front of you. But I'm also realizing too that that's actually probably a bad thing, because typically when I say no in person, I can demonstrate empathy. I can just listen, but listening in person is different than listening on the phone. When you're listening on the phone, sometimes the patient will ask you if you're still there. If you're listening in the room, they can see, as long as your eyes are making eye contact with them, they know that you're not drifting off somewhere, right? And so that's different. Because a lot of our discussions with our patients are negotiating that this challenging topic really requires a two-way interaction. So video visits can help. So if you've been able to roll out video visits, that's a great way to do it. A lot of our patients have technological challenges, and we've not been able to do that. But even a video visit may not be as effective as in person. And so I'm thinking that my fear is that while saying no is easier, is that saying no being harmful? Is the patient then going to be using other substances? Will they be supplementing their pain relief with alcohol or other substances that may not typically be used when they're in a more resilient setting? So I'll transition over to Nadejda on that to kind of facilitate our discussion with the group here.
Well, yeah, I don't know. Do we have a situation where we can actually hear people?
Carmen?
Carmen, can we hear attendees?
Yes, I just granted everyone, I unmuted everyone, so you can manually click the microphone icon on your control panel, and it will turn from orange to green, and then we'll be able to hear you.
Okay.
Great. You're also welcome to, if you just want to put something in the chat box as well.
Yeah, so the two things that would be really helpful for us would just be to hear, where you work and what your role is, and then also what you would like to get out of this webinar, if there are some specific challenges that you all have been running up against in your settings that you'd like feedback on. Just take a couple of minutes here and thank you in advance for your willingness to give us a little something here to work with, just so we can feel oriented. For what it's worth, we can't see any of you. We're looking at our own slides and looking at a tiny green light and just trusting that you all are in fact out there. So any sign of presence would be lovely.
Let's see. Yeah. Yeah, everybody should be unmuted. And Andrew, if you can click under the attendees drop-down menu,
Yep.
you will see orange, green, and a little hand.
Yep.
You click on the green microphone. It'll tell you if you want to unmute all panelists, and just say yes.
Okay, thank you.
Welcome. So now everybody is...
Martin, thank you for your presentation today. I can't figure out how to use a chat box, but I can talk to you.
Yeah, that's
Thank
great. Woohoo, you win. You get a free prize. I'm not sure what it is, though. They'll probably come up with some sort of incentivization system. We'll do better next time.
Gina, would you be willing to share what your role is in the context of your setting and what prompted you to sign up for this webinar? Anything that you'd like to get out of it, challenges that you're finding related to treating pain or
I'm a family medicine obstetrician in Lebanon, and we have a very high opiate use disorder kind of population within my practice particularly. And so, and we've made a lot of transition over to telemedicine. And so I was really hoping to kind of get some information, like you said, Andrew, about how to provide empathy to my patients through video, because that's been a really big challenge. We've also had to do like MMAs and other kind of updates on chronic pain and things through the video. And so those are some of the challenges I've faced in the pandemic so far.
Great. So Gina, I don't know if I can necessarily talk, we can talk a little bit about empathy, but I will say this, that one thing I really want to dial in on is on some policies and procedures that can reduce stigma and hopefully increase, and by nature, hopefully make it demonstrate more empathy, just simply by how you operate and how we operate as a system.
Thank you for sharing and introducing yourself, Gina. Anybody else be willing to introduce themselves and give us some context?
And honestly, if that's it, then I can just run with that. So
yeah.
No worries there. But anybody else that would like something specifically, that would be great.
And jump in at any point. I think we can move forward.
I got a question. Is there option to connect pain clients, online groups to help with the isolation, a non-opioid options? And that question is coming from Jody Lawrence.
Yes, can you say the beginning of the question again, Carmen?
Is there options to connect pain clients, online groups to help with the isolation, and non-opioid options?
Okay. We will, so in terms of, thank you for that question, and I will circle back about that. I don't know of any online groups per se, but it's something that I could look into, and there are definitely, lots of resources for non-opioid options for patients that I can send out to this group.
Yeah, I definitely, I've heard anecdotes about there being a lot of these, especially in the recovery community, a lot of online recovery meetings. But it's really interesting you bring up. So the group visits with patients with chronic pain, super helpful. We have not been able. We've struggled with trying to do an online kind of group visit model. You've yet to pull that off because, again, a lot of our patients, so our patients are about 70% Medicaid, 10% Medicare, only Medicare, and there's a good chunk of dual eligibles as well there. So the technological barriers are massive for our patients. And so we've been sort of stymied with, we really wanted to do group video visits early, but then just getting video visits off the ground has been a challenge for us. So I appreciate that. But yeah, we'll definitely have that as a to-do follow-up item. Thank you.
Mm-hmm. Okay.
So let's talk a little bit more. So this is I wanted to share this with everybody. I don't know if you've seen this. This is from the Kaiser Family Foundation, which does a lot of national surveys and data on just health in general. They've looked really into, they did a really nice study about just the impact of the coronavirus and the pandemic on our population. So this, what I like about this figure, well, it's sad. Obviously, it's devastating to see. But when we look at our patients that struggle with chronic pain and addiction, and by the way, I just want to call out just for a little bit here. I know that the lecture topic was specifically, chronic pain, but in my mind, to adequately address chronic pain in primary care, having a decent understanding of addictions and the processes they're inherent within is really vital. And so while we may not, while we may be talking a lot about some of addictions work here, I think that the two definitely, obviously, if you can imagine the Venn diagram there, there's a lot of overlap, right? So if we think about our patients who struggle with addictions and chronic pain, they're probably going to be in the bottom of these two bar graphs for only fair or poor health as patients rate their own health status. And if you look at the coronavirus, pandemic and the impact on them, they've felt that almost 40% of those patients they describe it as having a major negative impact on their health. And that's a significant number. In other words, if you look at a prevalence of almost 2/3 of a decompensation of worsening chronic disease, that's huge, right? Versus 50% of our population that's otherwise healthy. So it's really useful to think about it this way, and helpful it's one of these things where in my mind, we just should be assuming this. This is like a kind of a universal precaution. Another slide I wanted to share with you, this is from MMWR, which until recently was unpoliticized CDC reporting. That's, as you know, this is their weekly journal, Morbidity, Mortality Weekly. So they released this in August, and it shows a survey. So in late June, there were 40% of US adults were reporting that they were struggling with mental health or substance abuse due to the pandemic. So if you look at that, 13% started or increased substance use, 11% seriously considered suicide. It's trauma and stressor-related symptoms were 1/4, and 1/3 noted anxiety and depressive symptoms. So this is across the US population, independent of health. So we know this is a burden, and we're starting to see more and more data. The problem is, for those of us that do claims-based research or death monitoring, like, if you're looking at vital statistics information, that has a huge lag on it. So what I'm showing you now on this slide is, we just got this a week ago from OHA, that's showing of an increase of 70% in opioid deaths during April and May of 2020 when compared to 2019. You're wondering, well, Andrew, what about June, July, and August? Well, again, if you know how the vital statistics things work, it just takes a while for this stuff to kind of get uploaded and analyzed. Same thing with claims. So we're going to be seeing a ton of stuff here probably this fall or this winter about what we've been seeing initially. But right now, it doesn't look great, obviously. This shows they suspect that 70% increase maybe is probably because of illicit fentanyl. We don't know how much of this is corona related necessarily to anything else. But it is to be, it is a great reminder of how anybody, and I mean anybody, I've got patients that are on tramadol that they have at home a Narcan prescription. They've got it filled, their family members know about it. Anybody that's on chronic opioids, regardless of the level, strong recommendation, have them with Narcan. So this is just a reminder of that. Even if we're thinking in this situation of patients who are using illicitly, it's just a good reminder of anybody should have Narcan. A little bit about our objectives today. I know this is usually see the slide first. We wanted to do a nice lead in. We're going to talk a little bit more about addiction care and how it's been integrated into primary care. talking about stigma. We're going to talk a lot about stigma, and then look at how policies and procedures can support the practice of change in during this pandemic. So this is, as we've all had more time at home and not a lot to do, or a lot to do, but no real interest in doing it, sometimes I get a little distracted. And so I found this amazing feature where I was able to, if I could come up with a picture of what it's like to be in healthcare, and that's any aspect of healthcare, right? Mental, dental, or behavioral health. Basically in 2020, this is what it is. We've got 2 people fixing the plane, or 4 people fixing the plane. We've got pilots on board the plane, and it's flying actively. And there's also just a massive poop emoji over everything, with a weird fairy somewhere around with some pixie dust, because occasionally we get these like moments of clarity and brilliance. And I think this is sort of, for me, the summary of 2020. So I just wanted to demonstrate some empathy there.
Lovely.
Thanks. Yeah, I kind of want to trademark this, I'm not going to lie. So another wonderful, beautiful picture here. This is when we talk, in my mind, about chronic pain and addictions in primary care. What we've really been working on, and I've been working locally here in Portland with our corrections system, really helping our staff that work in community corrections, the addictions community, here or regionally, the idea that addiction is a chronic disease. I think intuitively we understand that because we know that it doesn't go away, but we don't necessarily associate metrics or have a better nuanced understanding of what it is like for it to flare and to go into being well managed, and stressors making it worse or better. And so what we've really tried to do in our group and our community here is really have people think about addiction and pain like diabetes. And then we can make nice analogies there where, even if you, as we know, even if someone has diabetes and it's diet controlled and their A1Cs are under 5.9, you're like, oh, that's amazing. We also know that it takes one stressor, or one big bender, a holiday bender, if you will, to get the sugar up and potentially put you back in a diabetic status. So you're never quite recovered from diabetes. And I think the same thing can be said about addiction. Anyone that has addiction that's well controlled can tell you, as we probably most of us know, that that's not going away, and it needs to be actively managed. The catch, though, is that analogy falls apart a little bit. Nadejda and I were presenting in Seattle on this, talking about this disease model, and someone said, yeah, you know what, I get the analogy there, but when people don't sell their kids for cake, right? In other words, if you're talking about that, so we think about that, it's where people aren't, insulin, one of the treatments for diabetes is insulin, right? You're not going to sell your kid for insulin, right? It's going to be covered. There's no seeking behavior. There's no dopamine feedback loop when it comes to dopamine. The whole dopamine spectrum is not involved when it comes to diabetes. However, if you're on a medication for addiction, it does have that dopamine involvement, and it can obviously people can be really forced into some stigmatizing and illegal behaviors because of a medical condition. And so that's where it sort of falls apart. I wanted us to also read this slide here, and I can
read it if you want.
Sure.
So just to read out loud for those, just to help, depending how we all process here. Chronic amphetamine and heroin users show deficits in a range of cognitive skills, including verbal fluency, pattern recognition, planning, and the ability to shift attention from one frame of reference to another. The decision-making deficits resemble those observed in individuals with damage to the prefrontal cortex, suggesting that both drugs alter function in that brain area.
So as we think about what that slide means, it's that when you're struggling with addiction and dependency, where you are in your brain is thinking about what's ahead of you in 2 hours, maybe a day ahead of time. You're not able to get into that prefrontal cortex where you're thinking months and years down the road. You're stuck in a fight or flight. You're kind of stuck in that limbic brain for survival, more so than the area of the brain where we're thriving.
Just to add one thought about that, just how, you know, one of the challenges when people are in the throes of addiction really is that a lot of the behaviors that are in fact symptoms of the disease can really compound the sense that and the judgment, the stigma around you know, that people struggling with addiction are less moral, are bad people, are making poor choices, when in fact, you know, they are being really driven by this illness, and it can make it complicated to have people kind of the shift in culture needed to understand that really we are working with a chronic illness.
So if we think about that, and if you look at the center of this picture is a family that's working on recovery, and we've created rules, right? So we have all these things that they need to do to help kind of get their lives back together, or, you know, really start to, you know, get more and, you know, really start to dial in what they need to do to be successful. Well, if they're navigating housing, us as a medical team, probation, some food benefits, child welfare, so we're dealing with the state, dealing with what to do with the child care, also behavioral health. So that's all stuff that needs to kind of navigate it throughout the day. And there's also transportation issues. And so all of a sudden you've got, so in other words, if you're living within a part of the brain that's not letting you think more than a day or two out,
Or even a few hours out.
our expectation that people can pull this off is probably a little, just, I want to, when I say naive, I want to say that in the least stigmatizing way possible. It's just, it's a bit of ignorance that we have. And for those of us that have more lived experience, we know that we obviously are, this is more intuitive to us. But what I think what's important there is that when we have our office staff, or even our fellow providers, when we are working with them, we're working with our patients with these conditions, and the staff feel and see the behaviors that these patients are demonstrating. This picture of someone living within their brain, the limbic part of their brain, not the prefrontal cortex. This diagram we're seeing, to navigate all that in one day, that's a major cognitive load. That's planning, that's being strategic. And so if someone's late, if someone calls and is irate on the phone, or they come into the office demanding something, we don't know where they've come from. We don't know what's going on in their life. And as a result, do they get, you know, how do we react to them? But also, how does our staff internalize it, right? So it's, you know, we have our standards with our staff. You know, if you're going to threaten if our patient's going to threaten a staff member, we're not sure we can treat you anymore. I mean, that's I think most of us would agree. However, when we take a step back and we go, wait a minute, you know, how are we internalizing behaviors that may not be behaviors that are, that if you had other issues resolved, these behaviors wouldn't be there. In other words, if we, depending how you react to the patient the first time they come in the office, and or the first time they call you, or the first time they come to you for an appointment, and you say, this refill is going to happen, we can help you today. Or if we do something to sort of disarm the patient and make them feel more comfortable and safer, maybe we can avoid some of those blowups that we see, because the patient right now is navigating all this. So I think it's important for us to think about the things that we do and the stress that our staff internalize for things they can't control. It's like getting upset at the weather, in my mind, in some ways.
Just wanting to see the chat box.
Yes, all right. Okay, and so what we're talking about here is a little bit about our shifting as a medical community. And this is still an ongoing shift. I think that I'd like to think in the world that we're in, that we're more on the harm reduction a pathway versus abstinence when it comes to treating addictions. But I think that it's very much a mixed bag still. And there's also a lot of stigma in the community about this as well. So I want to take a step back too. So we're talking again about ways that we've created a system that our patients live in. And this is a controlled substance agreement that we had at Clackamas Health Centers that was there, that was live till about, I don't know, 2 years ago. And if you look at this, it's interesting. I know we need to do controlled substance agreements. It's a federal policy thing. It's, got to do it, right? Well, we delegated it to our behaviorists. I don't really look at these much, but the one time I look at these things, I go, wait a minute. I will not take a higher dose of any medicine, and I will not make changes. I am responsible. Medications will not be replaced. I will get these at a single pharmacy. So I'm sorry, but if you're a patient that may have housing instability and transportation issues, and you're seeing a page that says, I will get all these refills for medicines at a single pharmacy, what does that say? And so when we look at, or if I go to an emergency room, I'm going to tell the provider there that, I'm on a contract and I must do this and I must do this and I must do this. And it really is, there's just a different way in my mind to be setting up our expectations. So what we did was we tried to update this, and I can tell you right now, I still am not happy where it is. But now, the first line of our controlled substance agreement is, I will be treated with dignity and respect by this health center staff, and in return, I will commit to treat them with dignity and respect. And that I will not take a higher dose of medicine that my provider prescribes for me. And before I make any changes in how I take these, I will discuss this with my treatment team. In other words, we can't just say, oh, take your medicine as you see fit. Obviously, we're trying to create rules. But what we want to have this be is that this is a two-way street. This is not something where we're creating this culture of where what we says is gospel, what we say is gospel, and what a patient just has to go with the plan. Now, ultimately, one could argue in a cynical way, that's what a lot of this is. However, the dynamic that we're trying to set, therefore to change behavior and to dignify patients, is really the goal here. One of the biggest eye-opening moments for me in my medical career, and this is 5 years into private practice, was when a patient goes to me. I was seeing a new patient, and they were on some long-term opiates with chronic pain, and I looked at him, and he said, I went in the room, I sat down, I said, we did our introductions, and I looked at his med list, and he goes, I know you hate me. I can see it. I can see your eyes rolling a little bit. I can see how your body language is changing. You guys caused this problem. I didn't want to be on these opiates. I ended up on these opiates. I need them to function. Every time I go to the ER, they all hate me. I know you hate me. Sorry, deal with me. Now, that statement's loaded, right? One could argue that we take medications together, we do things collaboratively, but the stigma thing is real. And if we can land that plane about tapering and safe opioid prescribing with our patients a lot easier if we can avoid some of these microaggressions that we create throughout our system, or frankly, macroaggressions. By the way, one thing I wanted to call out too on this agreement is number 13, where we changed it and says that my provider may stop all of these medications if I fail to follow these rules, and my dose of medicine may or may not be lowered before stopping completely. In other words, we really didn't want absolute language in this because it's just not the reality that our patients face. When it comes to buprenorphine, I would like to challenge all of us here in the system that buprenorphine we should probably have a separate agreement entirely for, because buprenorphine is a medicine that we would use for, now of course, just a reminder for those on the call, anything like Subutex, Sublocade, Suboxone, and then the transdermal form all different butrans, all the active ingredient of buprenorphine, right? So that's the buprenorphine is the active ingredient in those. So this is a medicine that's safer. It's still an opioid. It's a partial agonist, and so it really helps the patients that struggle with opiate use disorder. Also, it's very helpful for patients in chronic pain. If you'd like to know more about that, happily would discuss more. But regardless, it's a lot safer. The analogy I give to my patients is if methadone or heroin or morphine were scissors, like regular conventionals, like razor sharp scissors, buprenorphine is safety scissors. You can cut paper, but you can't cut your finger. And so what we decided that for our patient agreement there is that it's really something where we want to congratulate patients for seeking safer care. We also want to know that, we really wanted to call out respect and dignity. And we also brought up too about like urine drug screening. So we said that, urine drug screening is required by the federal government. We also use it to ensure that you're safe and that you're taking your medication. And we said that, we use drug screens to support honest communications. And if you're unable to provide a urine sample, it could prevent your prescriber from giving you your medication. Why do we say that? Well, we do have patients that have issues where they're unable to produce urine sometimes, absolutely. And I have seen it as medical director for the last 7 years or 8 years now. I can tell you, when someone refuses to give a urine sample, it's not always the case that you think it is. And so really checking some of our expectations at the door and creating policies that don't shoehorn you in is really important. One final thing too is requiring behavioral health. That used to be a belief about buprenorphine. Well, we're basically saying that having a mental health support system is key, and as long as you are going to get medicine from us, we just ask that you have a connection, and we try to keep that really broad. Now, of course, when we throw in COVID into all of this, and just infinite stress tests, right, constantly, because now we have financial struggles, we've got policies, we've got distancing, we've got a new environment overnight for those that we care about that are disproportionately impacted by pain and addiction. We're also worrying about risk. What do we keep in these situations? Why do we need to do what we're doing? Are we going to get in trouble from the feds? What does our support staff need? And how do we keep our patients and our staff safe? These are all things that we're concerned about in this new environment with COVID. So making it work, so guiding principles. So when MAT meets distance, how do you make it work? Well, we really want to make sure that our care teams have integrated behavioral health. If you don't have the luxury of that, what's your strong connection with behavioral health, a behavioral health partner that you meet with regularly? And how do we follow patient-centered principles of addictions management? And then do we have a way to stratify by risk? And we can talk about that in a minute. And do we have the ability to perform basic case management? Is someone working the roster? Because do our patients fall off, right? If we have 50 patients on buprenorphine, is someone looking at and looking at that spreadsheet and looking at the last time they were in, and are they doing an outreach call? If we haven't seen them in 3 months, what's going on? Where are they? How can we help reach them to hopefully maybe even bring them back in? And then also, looking at how we adapt our systems to allow for phone and video visits. So here's a guideline. So this is what I would suggest, and I'm happy, like I said, these slides, you're welcome to use these slides. These slides are reflecting what we're probably going to be adopting, at least in the Tri-County, hopefully statewide. So if you're on a partial agonist, that's a buprenorphine-containing product, and we have a pandemic, and so we know this pandemic, we assume, is probably through next summer, if not next fall. No matter what, we're saying that, we probably need to see you twice a year in person. Because as long as we're able to do some in-person care, it is important. We're going to need a drug screen to some degree, and we just want to check in on you. We want to lay eyes on you because we know that in-person interaction is vital. The standard for low-risk primary care patients is 4 visits a year, and so what we're saying is that we can do 2 of those by telemedicine by the prescriber or an integrated behavioral health clinician. In other words, if we have at least at Clackamas, and I know we're very fortunate, so when I say this, it's not expecting you to be able to replicate that. I'm just using it as an example. At Clackamas, we have 2 behaviorists that just do MAT work, and they're very skilled. And when they're my eyes and ears. And so when one of my patients comes in to see them, and I haven't seen my patient in 4 months, and they've seen them and they've done a good check on them, I'll see my patient in a month, and I'll bridge them for a month, because in my mind, if they see my behaviorist, it's like they're seeing me in the interim. I mean, I only really need to see them a couple times a year in my mind. So really pushing that envelope and engaging your care team and asking yourself difficult questions like, why does someone need to see me as the clinician versus someone else who is a mental health professional? What am I doing that's any different if these are reasonably protocoled visits? For patients that are higher than the lowest risk patients, they should have more frequent visits is another thing we're proposing. But again, we really want us to be flexible with the care team. Now for full antagonists, so this is if a patient's on Vivitrol, and if there's I don't know if anyone here on the call is on or has patients that are on Vivitrol that does it. It's an opiate blocker. It's a monthly shot. It's sort of like your long-acting Haldol or Risperdal, but in a similar formulation, but for patients that have an opiate use disorder. We've talked about how we can alter these as well for our visits. So we really want this is a much higher risk population. So we're talking about a lot of these are going to be in person because you're giving the injection. But just looking at could we kind of you know, if someone's stable, for example, if someone's been coming to us every month for a year and a half to receive their extended release naltrexone, do they really need to see the physician or nurse practitioner every single time they come in for the injection? If you can put standing orders in place that your MA, if you create an MA only schedule where they're doing flu shots and they're doing, you know, drug screens and point of care testing, could they not do a Vivitrol injection as well under an order that's in the chart? Of course, they totally could. They should have a meaningful touch, but that could easily be with a behavioral health clinician instead of having a provider there, as long as there's policies in place that you're following. So that allows you to have more flexibility, because I don't know about you all, but we are doing rotations of providers. It's a little chaotic to get in to see providers in person if they're your PCP, or if, heaven forbid, you have a COVID outbreak and people are in isolation. We've now had 3 COVID cases in the last 2 weeks, and it is a nightmare. Thank goodness we can do remote work. So we're trying to be with maximum flexibility and make this stuff work. This is a risk stratification tool we created for Clackamas Health Centers. I won't go into this now, but I'm happy to share it or discuss. Carmen will be sharing this handout with you all. I've already given it to her, and I'm happy to talk to you offline about that. For our new MAT patients, we are actually, like I said, we've got about 15 minutes left on this call. I'm happy to talk a little bit about this. We've already talked to some degree what these are, but when you're thinking about, for example, if you have someone who you want to start on buprenorphine, we're being challenged right now with distance with the remote work, because the visit setting has become an issue, how we get urine drug screens, and then how we provide collaborative care. In other words, mainly one of the cornerstones of urine drug screens for patients with addictions is that they're random. Well, why are, you know, and so if you're not going to be coming into the office all the time, and we need you to come in this time, the likelihood of you producing a urine on that visit is going to be pretty strong. So if there is diversion going on or other substance use, that does create an issue. However, I would then ask us to challenge ourselves. What are we looking for when it comes to urine drug screens? In my mind, if you're on buprenorphine and you've got an opiate use disorder, I want to make sure you're not just selling it. Okay, yep, that makes sense. But if you're on meth, or if you're taking if you're on marijuana or methamphetamine, a lot of times people will they'll doctor their urine drug screen because of a polysubstance issue. If you can build trust with your patients and have in your policies that say, hey, we're doing a drug screen to have a conversation, and if you ask your patient before you do a urine drug screen and say, hey, I'm going to provide you a medication today with a refill, but I'm also going to do a drug screen, and what you tell me won't affect how I'm going to prescribe this medication for you today. I just need to know what's going to be in the urine. And I've had patients admit to selling it when I've put them in that safe zone. I've had patients admit to pretty much any other substance use. And sometimes they've obfuscated and they've kind of pulled the wool over my eyes, but eventually they'll come around. And I think that as we think about how we can destigmatize in the pandemic setting, that helps us destigmatize overall, because the more we can have truth and honesty with our patients that we're providing, honestly, opiates or MAT, I think it's a win-win.
Do you want to pause and just see if there's any questions?
Because this is provocative stuff. I mean, we're coming from a world where we were basically saying, if you're on any other drugs, I mean, up until what, 2013, heck, 2016, 2017, sometimes now, if you're on just, you know, say for example, if you're just on morphine, or if you're on buprenorphine, a zero tolerance policy, I mean, that has been a very recent shift. So I would not be surprised if that's still shocking to a system.
Does anybody have any questions or comments?
We do have a question from Albert Fan. He says, any tips on keeping patients compliant with drug screening since they are not coming in?
That's a good question, Albert. So they're right, they're not coming in. And so, like I said, that MA schedule is really important. I think that if you have integrated behavioral health, I think that helps as well, because a lot of times they might have more flexibility in their schedule in getting people in. But I really think creating I mean, we're doing so many things in drive-through. I've yet to see someone do a drive-through urine drug screen. There's probably a joke there about truckers peeing in water bottles and throwing them on sides of the road. But outside of creating a literal trucker bomb, I can't think of a way to do it in a car. But I do think, though, that one tip would be that, releasing a medication after someone comes in for a drug screen would be a great way to do it. In other words, you've got it pended, your staff can call it in, we just need to have you produce a urine. And again, there's two things on that. So what if the patient comes in and their drug screen has other substances in it, along with buprenorphine? Okay, that's a conversation. What if a patient is negative for buprenorphine when you do the drug screen? Well, you provided them 30 pills and they're going to sell those 30 pills, sure. Buprenorphine is safer than other medications. A lot of times buprenorphine is sold to patients who use heroin and they don't want to go in withdrawals, or they don't want to shoot heroin anymore. So a small amount of buprenorphine that leaks into the streets, one could argue, is actually it's good for the public health. And so heaven forbid someone can sneak in on that. It's not, in my mind, it's not the end of the world. The other option is point of care urine drug screen as well. But again, even if you have to send it off, I don't think it's the end of the world if someone's diverting.
Any other questions or comments? Okay.
Well, we do. Thanks. Yeah. So I did want to talk one thing about the last slide here. So really creating an intake process for patients desiring addiction care is really helpful. And so kind of creating a pathway for your call center, or however you take calls, would be useful. And so the one thing I want to say, though, is that if you do it right, there are no rules that says you can't prescribe for a patient the first time you see them over the phone or video. You don't need to see someone in person to prescribe them the first time for buprenorphine. So just so everyone knows, I mean, you need to see them soon, and one could argue within a week or two. But from a harm reduction policy, you can do that. And Nadejda, I will stop there. I know you wanted to have something else to say too.
Oh, I wanted to make sure we had a moment to circle back to Gina's kind of question about expressing empathy virtually, and of course, welcome anybody else's experience and thoughts on that. But I'm a therapist, and I also work in private practice, and am now doing all sessions virtually, and so it's something that I have been thinking about a lot. How do we really have that and express a sense of humanness and validation and empathy in this virtual world that we're living in? And a few thoughts. One, members of our team often do trainings on how to have difficult conversations. And if you go to the Oregon Pain Guidance website, there are a number of resources there that really can kind of outline some strategies for and guidelines for how to have some difficult conversations. One of my favorite models is one that's called, the acronym is VEMA, V-E-M-A, that comes out of the VA, and it stands for validate, validate, educate, motivate, activate. And sometimes our difficult conversations trainings are really just about role play around validation. And any person who's activated either because of an increase in pain, changes in medications, anything that can come up when we're working with the patient population that we're talking about here, really one of the key things to remember can just be to be able to express validation about the anger, the fear, the frustration, the loneliness, the isolation, and that really until the patient feels validated by the provider, they really are not in a place of being able to internalize or integrate any kind of education or information that you might want to share. And so while there are so many different, we could spend hours on this kind of thing, I just wanted to say that it's something that I've been really drawing on in my own practice with people, even in some of these initial kind of intake screening calls I've been doing with people. I've been feeling like it's extra important for me to really name and call out things that might just go otherwise unnamed in an in-person context. Like I might really call out, gosh, I noticed that you're looking really upset, or it seems like things are hard, or looks like you might have some tears here. Just really naming what you're seeing more than you would in person was the thought that I had on that.
And listening on my end, what I've noticed that, like, so for example, there's two scenarios. Someone requesting an increase in an opiate, or someone that's on a taper that wants you to stop the taper. And so I think that the increase in opiate is not the end of the world. I would recommend, if you do that, say, I understand that. So what are the things that we can do to help you, so to not necessarily have this need next month? In other words, if it's the request is in October for November, say, okay, in December, our goal is going to be the following. I'm going to give you 2 months. One will have the increase, but the second month you'll be back to where you were. Or if you're tapering, if someone is articulating an inability to taper, you can say to them that, and you can absolutely empathize and say, you know what, let's hold the taper for a month, and then we'll taper you in a month later. And a lot of times, making them feel safe, and then schedule them 2 months out, so you don't have that in-between visit either. Because there's no rule that says you need to see everyone every month. And frankly, if giving someone a little distance sometimes can be really what's needed.
Oh, is this the correct time?
I believe so. Carmen, how are we doing for time?
Yep, we are doing great. And I don't see any more questions. So,
okay.
Yeah, I think it's great. Thank you for sharing your...
That's another point, sorry.
Yeah, just one more thought. I wanted to just speak to the earlier question also about resources for patients living with chronic pain. And I will follow up with a series of, some recommendations. And I just also wanted to call out that one of the things that we find is that, across the board, people that are working with individuals with chronic pain often really do not have background in training on contemporary pain science, or behavioral health clinicians and mental health therapists, as well as primary care providers and otherwise, really can benefit from training about pain, contemporary pain science, how to talk to patients about pain, offering resources, and that can be such a critical part of enhancing your practice and the pain, pain treatment in your setting. And so I will send along some resources for that.
Okay, Carmen, I think that's it. So thank you so much for your interest, everybody, and we'll give it back over to you.
Great, thank you so much. I just got a couple of thank yous and people enjoying your presentation, and they appreciate what the knowledge that you share with us, and any resources or recommendations that they can share with their patients would be welcome. And thank you so much. And from Oregon Pacific AHEC, thank you for joining us today, and thank you for participating today for everyone. Now let's take over and let's go over some details. To help us provide best future training events, please take a moment to complete the brief summary at the end of the webinar. And the webinar recording will be available within a week on our website. And feel free to reach out to me or our office if you have any questions or concerns. We'll be happy to be of assistance. And finally, to obtain CME or CE credit, log into www.eeds.com and enter the activity code. Once more, the activity code is the one that you're seeing on your screen. And thanks, everyone. Please complete the brief survey that will appear as soon as the webinar ends. And you have now completed the webinar, and you may disconnect. Have a great day. Thank you, everybody.
Thanks so much.
Goodbye.